much for having me today. My name's Gaulton. I'm a neonatology fellow here at HUP, and I'm so excited to tell you about healing at home. First, I want to talk about my story. This is my son, William, just moments after he was born here at HUP. Fortunately, he and I were healthy and didn't have any major medical complications. I was told that we had to stay in the hospital for 3 days after he was born to meet all of our discharge criteria, which was routine for vaginal deliveries. But working at HUP, I wondered why we couldn't leave earlier. I was familiar with the discharge process. Why couldn't we leave earlier? What I wanted more than anything was to get back to my daughter and husband and bond with my son in the comfort of our own home. So I wondered if other patients at HUP felt similarly. In fact, we found that 80% of low-risk women who had vaginal deliveries also wanted to go home earlier. That led us to the question, well, what's stopping us from sending them home earlier? To answer this question, let's walk through a typical hospital experience for these patients. The average length of stay is 50 hours, or 3 days. The baby's health screenings are typically done at 36 hours. When I stopped to think about this, I asked, well, why is this done this way? Why is it done at 36 hours? The answer I got was, that's just how it's done here. This is one of the hardest problems to solve in healthcare. But we know that doing the baby's health screenings as early as 24 hours is safe and the standard of care at other hospitals. And we know that mothers are ready to leave at this time. So they're just waiting around for their babies to be discharged. To put this into context and understand why this is important to the hospital, let's talk through what should happen ideally. A pregnant woman comes to the hospital in labor, gets evaluated at the perinatal evaluation center, is moved to labor and delivery where she gives birth to her baby. Shortly after delivery, they're moved to the postpartum unit where they stay until the time of discharge home. As you can imagine, discharge delays create a bottleneck and back up the entire flow, preventing women from going home. Not only does this decrease our capacity to deliver more babies, but this also leads to women giving birth to their babies in unsuitable places, such as hallways and triage areas. All of this leads to a negative patient experience. But the story for mom and baby doesn't end in the hospital. When I got home, even with a supportive husband and coming from a medical background, I felt like I was falling off of a cliff. Like other women, I wasn't going to see my OB doctor until 6 weeks after discharge. During this time, I felt anxious and isolated. When mothers get home, they need more support. Many struggle with postpartum depression, with issues related to breastfeeding, with pain. And many, especially at HUP, don't have the social support to help them get through these issues. Imagine being a stressed out, tired, new mother trying to care for your baby, sometimes alone, and having to sift through a whole bunch of information on the internet, trying to search for an answer to your basic question because you don't want to wait for your doctor's office to call you back. Sometimes it takes hours or even days. Now, I want you to imagine a new health system. One that supports moms and babies based on their individual needs in an environment that they wanted. The Healing at Home program aims to redesign the postpartum experience by streamlining inpatient workflows to decrease length of stay, supporting moms and babies as they transition home, and once they're home, individualizing services to provide high-value care. This is the current system, where services in the hospital and home are disconnected. This is the new system that the Healing at Home program has created. First, we reduce the time in the hospital, and then we provided targeted care at home to keep patients there safely. Let's start by talking about the interventions that we tested in the hospital first. One of the reasons that length of stay projects traditionally fail is that there's so many provider teams involved, which creates fragmented communication systems and interdependencies in workflows. We initially presented the idea to move the baby's health screenings earlier and met resistance. Some clinicians were worried that patients would have comorbidities when they got home. Others were worried that they would feel pushed out of the hospital too soon. Ultimately, we were able to convince our stakeholders to move the health screenings back to 24 hours for all 50 vaginal deliveries during our pilot period. But we had to do a couple of things first to make them feel comfortable. Our team modified existing clinical protocols for all of the provider teams involved. That was not easy. For the nurses, for example, we used the cards that they already used, moved the timeframes earlier, and then made the cards green, not rocket science, so that they knew that their patient was on this new clinical pathway. Our innovation team spent a lot of time on the ground facilitating communication and coordination in order to improve efficiency. Ultimately, we were able to reduce length of stay by 40%. This was a 19-hour decrease, or one less hospital day. Not only were we able to reduce length of stay, we were also able to do it safely. None of our patients were readmitted or seen in the ED during the first month after discharge. Now, I want to move to the interventions that we tested in the home. We listened to our patients, and we knew that they wanted more easy access to medical advice, and we knew that they would have a ton of questions. So, using Way to Health, thank you, David, we created Penny, a personalized postpartum assistant, a text bot that provided rapid, clinician-approved answers to questions at the touch of a button. Our team answered over 2,000 texts from 92 patients in the span of 2 months. Once patients texted us once, they were hooked. They texted us, 96% texted us 2 or more times. Moms told us that they loved this program. One woman said, "I want to give you 100 stars, faster and more direct than looking online or calling my doctor." We also found that the #1 struggle that patients had once they got home was with breastfeeding. I can definitely relate to this. 40% of our patients needed additional lactation support. We were able to do this in a targeted, high-value way by first triaging their concerns by text, and then for those who needed it, we helped facilitate telemedicine or in-home visits. 100% of patients told us that this was critical for establishing breastfeeding. For our pilot patients, we also facilitated private nurses going into the home, evaluating mom and baby to ensure their safety. This was covered by their health insurance. Through our pilot, we were able to improve healthcare utilization by preventing unnecessary pediatrician and ED visits, catching medical problems earlier, and appropriately referring patients to their doctors when needed. Looking to the future, there are many benefits to Penn and our payer partners. We believe we can increase throughput and capacity and decrease unnecessary healthcare utilization. By expanding the Healing at Home program to all of the delivery hospitals across Penn, we believe we can decrease length of stay by 40% for over 3,000 patients a year. This is for vaginal deliveries alone. Imagine what we could do if we expanded to other patient populations. Increasing capacity would lead to a $1.5 million contribution margin for Penn. Now that we understand the problem better and believe that the Healing at Home program can have a positive impact, we want to further refine our interventions and test them at scale. Ultimately, we want to provide parents with the care and support that they need so that they can focus on those first precious moments bonding with their babies at home. Thank you so much.